Welcome to the last renal biopsy session in Renal Grand Rounds for this academic year, as Matt pointed out. This first case was originally going to be a joint presentation of Dr. Osama Amro at Swedish, and I hope he's on the Zoom. We'll check that in a moment. And Dr. Najafian, and I feel compelled to point out that Dr. Najafian's son stepped in and altered the plan by breaking his foot. And so Dr. Najafian is engaged in taking care of that issue this morning. And so I will be stepping in and showing Dr. Najafian's slides. I won't be able to bring Dr. Najafian's flair for education, but we'll see if we can still learn something from this case. So I'm going to move to the first slide. So I've made a couple of clinical history slides, and Osama, if you are available, you can present it.
Thanks very much for inviting me. Can you hear me well?
Yes.
Yes. Oh, great. She's a 65-year-old Punjabi-speaking lady with Sjogren syndrome, not in any immunosuppression, has a history of cryptococcal pneumonia in 2018, recurrent UTI and pyelonephritis, admitted in May with fever, chills, unclear etiology, and developed rapid worsening of kidney function. And a kidney biopsy was obtained. The urine culture, she was treated for UTI, but the urine culture was negative at the time of her kidney biopsy.
All right. And so she was started on steroids. And
correct. She was evaluated on immunosuppression with the concern that this is an autoimmune process, and a kidney biopsy was obtained.
Right. And she had some lab data, which is shown here for everyone. An elevated serum creatinine, urine protein creatinine ratio, as you see. I think critically, urinalysis, right? With red cells, white cells, no casts. And for some reason, we're getting a lot of echo here. Serologies, as you see, and a high SED rate. So given all that volume of information, while we have everyone's attention, we can ask the group, does anyone want to venture a clinical diagnosis? And to move things along, I guess if you use the chat, Matt, you'll have to read the answers. I can't see it in my full screen mode. Or you can unmute yourself and shout it out.
One vote for tubular interstitial nephritis from Dr. Kerala.
Okay. Tubular interstitial nephritis from what? That's a broad category.
Sjogren syndrome, he says.
All right, good. I was going to say it's like saying glomerulonephritis, and we've learned that we want to be more specific than that. Anyone have any other thoughts about this?
Leah likes IgG4 related disease.
Thank you, Leah. Anything else? Anyone want to go for a vascular kind of phenomenon? Lots of renal failure here, right? We've got pulmonary issues, renal issues. None of you guys are going to go take the opportunity. You might regret it.
Brendan likes MPGN and cryoglobulinemia. A ball right. Has a second vote for sarcoid-related tubular interstitial nephritis.
All right. Well, at least we have a reasonable differential to work with. So in the interest of time, we'll jump into the biopsy. Wow, what an ugly looking kidney biopsy, right? Very likely to be diagnostic of something, but not good for this patient. So you can see on the left at low power, an intact glomerulus, and that's just about the only thing that's intact in this biopsy. There is a diffuse interstitial inflammatory cell infiltrate. It obscures some of the tubules, and we'll get into that. And it is loaded with cells, including many with very dark staining nuclei. And just taking another look, and again, this is in the cortex, and it's really kind of important to keep that in mind. And so you can see this diffuse infiltrate of cells, and in some places you might even see this collection of dark cells that look like maybe it's even forming an abscess. And as we get closer and look at this infiltrate, a lot of things in this picture. One is some of the tubules are loaded with luminal leukocytes, neutrophils, pus casts, if you will, even though we didn't see pus casts in the urinalysis, white cells, but not pus casts. There's a diffuse inflammatory cell infiltrate, including neutrophils in that infiltrate. And while the tubules aren't exactly overrun, I call your attention to the fact that many of them show disruption or even loss of part of their basement membranes. This is a very destructive tubulointerstitial nephritis. So here you see the loss of basement membranes. Up here you see the destruction of tubular basement membranes in tubules that are clearly involved by this inflammatory process. Stepping back a little bit, at some of the most involved areas, again, we see this diffuse infiltrate. We can see now recognized leukocytes in some of the tubular lumens. But importantly, there seems to be these aggregates of material that's also around the tubules, an eosinophilic material that looks like fibrin, fibrinoid material, possibly even necrotic material that surrounds many of these individual tubular lumens. And some of this material seems to be present in structures that we kind of recognize as peritubular capillaries. I wouldn't quite say this is a peritubular capillaritis in which the walls are inflamed, but there appear to be aggregates of this fibrinoid material, both within peritubular capillaries and again in the adjacent tubulointerstitium. And here we're seeing this at higher power. So just in case you didn't see it before at lower power, this is this aggregate of inflammatory cells and eosinophilic material that surround tubules involved by this tubulointerstitial nephritis with this destruction of the tubular basement membranes. Looking at it in a different color, in H&E, this is useful because for some, it's a lot easier to recognize the neutrophils that fill some of the tubular lumens, and it's easier to recognize, and here I'm going to do this largely by memory, that there are some eosinophils in the inflammatory infiltrate. And I say by memory because I'm one of those Caucasian males that's partly red-green colorblind, and I don't see eosinophils the way some of you might, or most of you might. All right, so a big, active tubulointerstitial nephritis. We've got that part right. Any further thoughts about what this is? We've had a very interesting clinical history. We've had a history of past UTI that's been treated and is now culture negative. And we've had this story of Sjogren's. We've had pulmonary infiltrates. Any other thoughts now that you've seen the pathology, or at least the histology?
Any suggestion of adenovirus?
Adenovirus. It's a good thought. No one saw characteristic inclusions, but it is my understanding that an adenovirus stain was done and was negative. Other thoughts? So do you think it's what? Pyelonephritis, something else, Sjogren's? We had those possibilities, IgG4.
We have question, could this be COVID or renal TB?
Would like those thoughts. So COVID, kind of interesting. I don't think we know enough, but we know the principal pathologies that have been associated with COVID have been thrombotic microangiopathies, collapsing glomerulopathies, acute tubular injury, but I'm not aware of descriptions of a florid interstitial nephritis like this. I'll wait. I'll just address TB and then go back to Dr. Amro. With TB, we might expect to see a more granulomatous response. This is really an acute inflammatory response, so I think it wouldn't be typical. So, Dr. Amro, do we know this patient's COVID status?
Yeah, it was tested twice. It was negative. I think this is a good thought in the time of COVID. Everybody's COVID unless proven otherwise.
Right. Well, I think at least with that information, we can exclude that as a possibility for the current renal lesion. Any other thoughts before we move on?
Could this be lymphoid interstitial lung disease with tubular interstitial nephritis?
Ooh, I don't know. I don't know enough about the lung disease in that setting. I don't know. What do you think, Dr. Amro? Well,
Sorry, I did not hear the question very well. Hello, can you hear me?
Question is from Dr. Kerala. Could this be lymphoid interstitial lung disease with tubular interstitial nephritis?
Oh, that's very good thought. Actually, that's what the rheumatology think of the lung involvement in the pulmonary. So yeah, but whether we connect these together or not, so this is a good thought. But the lung involvement, that's the thought.
okay. So we've got some working diagnoses. I want to show you one more histology picture. So everything I showed you before was in the cortex. This is the medulla. Where did that inflammation go? There isn't any. So this is very uniquely, it would appear to be, because it's a good biopsy, you're looking at a good sample of both, an inflammatory process that involves the cortex, but not the medulla. Does that change your thinking about what your clinical pathologic diagnosis might be? We'll move on, but I ask you to keep that thought in mind as we proceed through some of the other pathologic findings. So let's move to immunofluorescence and see if we learn anything from it. Here's the immunostains for IgG, cortex, and medulla. I hope everyone looking at this can see there's something quite different between cortex and medulla. Anyone want to venture what they see in the cortex? And you can just speak out. Oh, man.
Well, you see essentially linear staining of the tubular basement membrane, right, in the cortex with stains positive for IgG, which is absent in medulla.
Absolutely. Absolutely see that. I might even point out that I'm seeing some Bowman's capsule staining too, but the dominant thing is clearly tubular basement membrane staining, cortex versus medulla. And I didn't quite catch if you said this, Yoshio, but you can get help from any of those fellows who scored so well in their exams in the pathology section. Is this granular staining? Is it linear staining? Does it make a difference? Oh, I long for the days when we meet in person again so that I can call on people and and we can elicit that kind of dialogue. This is linear staining, and it does make a difference. All right, so let's go and re-examine. So as you may know, we make a screening section and we stain it of the frozen tissue, both at the start of obtaining the levels we use for the immunofluorescence studies and at the end. On the right is one of those screening sections stained with an H&E so we can recognize what we're seeing. And you can see in our sections, we have both medulla, cortex, and corticomedullary junction. And if you go back to the slide with the IgG and see what did we stain, we see that the medulla is negative, and right at the corticomedullary junction where we get cortical tubules, we now see again the linear staining of cortical tubular basement membrane. So this is a cortical defined process. Okay, what about other reagents? So C3 normally stains tubular basement membranes to some degree a little bit. Remember, C3 is made in tubules, but this diffuse linear staining that matches the IgG, don't see that as a routine. This is probably true binding of C3 to immunoglobulin on the tubular basement membranes. Though it's coming across as very weak, there is some weak staining of C1q in the tubular basement membranes. Normally, of all the reagents we use for immunofluorescence, the ones that have the least amount of background and look the darkest are our stains for C1q. So to see this much C1q in tubular basement membranes, while not as strong as the other reagents, is significant. There was a peculiar finding. I'll mention it because it was mentioned to Dr. Amro, and he can see it. It won't be germane to our further discussion of this case, but a peculiar staining with the IgA was that it actually seemed to concentrate in proximal tubular brush borders. So here you see cortical tubules, here's their basement membranes, the dark space in between of the tubular cells, and its staining brush borders. I just bring it up because it was an unusual finding. We're not sure of its significance. We don't think this represents an anti-brush border associated disease in view of all the other findings, and in contrast to the case that was presented just a month ago. The staining for kappa and lambda light chains are equivalent. This is not a monoclonal deposition process in the tubular basement membranes. This is a real interesting stain. This is a stain for fibrin and fibrinogen. So if you remember, I was telling you about these accumulations of material around the individual tubular basement membranes. I must say I virtually have never seen a fibrin fibrinogen stain around tubules that looks like this. So again, reflecting a very active, inflammatory, and potentially necrotizing process. And just to remind you of what that looked like by the histology, these areas with this material and this very destructive tubular inflammatory process accompanied by clear demonstration of the deposits of fibrin in the adjacent interstitium. Electron microscopy. So remember, this was a linear staining process of tubular basement membranes, and it did not stain glomeruli. So what would our expectation be? Our expectation should be no significant immune deposits in glomeruli unless there's sort of incidental subclinical findings. And if it's analogous to anti-GBM disease, where we don't see discrete deposits the way we do with immune complexes, we probably shouldn't see deposits in tubular basement membranes either. So here's a low power view of a glomerulus, and in fact, all the basement membranes are intact, foot processes mainly preserved, and there is not a discrete immune complex deposition process in the glomeruli. And here is a little higher power, so you can see the mesangial areas, the capillary walls, endothelium, a little bit swollen, foot processes, largely preserved, not a glomerular injury process. Here's the tubules. Now we expect to see some pathology in tubules, but we don't expect to see immune deposits in the basement membranes. Whoops. So here are the tubular basement membranes. There are no discrete deposits. The tubules look awful. Why do they look awful? Look at these big spaces between the tubules and their underlying basement membranes and between each other. There's wide separation of the basolateral attachments of tubular cells to their matrix and to each other, and it's the loss of these attachments that's one marker of severe acute tubular injury. The other thing we're seeing is a marked influx of leukocytes, in this case in the tubular lumen with inflammatory cells, and that matches the tubulointerstitial nephritis that we had been seeing. Another look at tubules where there's tremendous vacuolization indicative of injury to the tubular epithelial cells. So this was Dr. Najafian's final diagnosis, and he was stuck with a quandary. We have clear features that would mark this as an acute pyelonephritis with neutrophils, both in the interstitium, the tubules, leukocyte casts, all of those things, and yet we have this peculiar tubulointerstitial nephritis with strong linear staining for polytypic IgG. Now let's go back to that issue of I showed you a clean medulla. How does that happen? I mean, when we think of pyelonephritis, we often think of ascending infections. We think of medullary involvement. It's so characteristic. But this did not have that. And that is unusual and, at least for me, kind of unexplainable. There's clearly this severe tubulointerstitial nephritis associated with the deposits of with the linear staining for IgG that indicates an immune phenomenon. So with some of these still peculiarities left outstanding, my question to this group is, if you could do one more test and only one. Your choices are limited to one. What would you want to do next? So I'll wait 1 minute while we let people either communicate via chat or open up their mute button and offer some suggestions. Help us figure this out.
The serum test for the tubular basement membrane antigen.
For an antigen, do we have any good tests for testing for tubular antigens?
Not sure.
Okay. Any other thoughts? So the test would be, can we identify a tubular antigen in the serum, whether it be by an ELISA or any other kind of test? Is that right, Abal? Do I have that right? I'm going to assume that we have that right. I said we'd only spend a minute waiting, and we will. So here's the test.
Kim has a suggestion: serum from patient on normal kidney tissue.
Okay, so we've got two complementary tests, but again, I only gave you a choice of one. I said we're trying to be parsimonious and do a single test. So we've got two options out there. Let me show you what we did. We took Kim's suggestion, and we have obtained patient serum, and we have normal kidney, and we put the patient's serum on the normal kidney, like so, and then we test for anti-IgG with polyclonal reagent that would bind that, and if it's positive, we should see staining along the tubular basement membranes. And what you see is the actual result of this test. It clearly stains the tubular basement membranes. Again, it's staining Bowman's capsule. And I would point out, in my opinion, and actually in Dr. Najafian's as well, it's staining strongest in proximal tubules, and it has some weak staining in some distal tubules as well, smaller and less pronounced. And maybe this accounts for the anatomic distribution of strong staining in the cortex and really absent staining in the medulla. So there it is, titered out. We got tired. It was still super strong. It titers greater than 1 to 640. We don't know how high the titer is in this patient, but it is really, really high. So the result is there's diffuse and strong staining of the tubular basement membranes, and we have convincingly, I believe, demonstrated the presence of an anti-tubular basement membrane antibody. And just a brief mention about some what we know about these sorts of things. Obviously, a rare condition. Long ago, a group at Minnesota and more than Minnesota and Kansas that included Ralph Putkowski, who for historical reasons you should know, along with Jürgen Wieslander, developed the assays that we now use for detecting anti-GBM antibodies as an ELISA. And they identified a tubulointerstitial antigen in tubular basement membranes, not limited to kidney, but it did have a preferential distribution in proximal tubules by a lot. Also a little bit seen in Bowman's capsule, distal tubules, and I think in a sense matched the distribution that we see in our patients. So, whoops, that went the wrong way. So that's what we know about this case. I'm going to let Dr. Amro jump in and give a little bit of follow-up, and then you can ask what you will. Osama, are you on still?
Yeah, thanks very much. This is beautifully put and truly a puzzling case. So we started pulse steroid, 1 gram, 3 doses. Creatinine peaked at 4.8. As of 2 days ago, creatinine 1.2 with a resolution of pyuria, and protein in the urine is 300 milligram based on spot protein to creatinine ratio. For other manifestation of Sjogren, which I liked because I wanted somebody else to help me with the immunosuppression. So we are weaning steroid down from 60 to 40. And one thought Dr. Najafian was mentioning, can we do clinical improvement with the anti-TBM titer? And that will be the next step. Will that guide our immunosuppression? Obviously, the titration of CellCept will be up slowly with the history of prior infections. So that's what we are at. So very, very significant improvement in the clinical manifestation of the disease in terms of creatinine and pyuria. We're hoping that we see this sustained improvement, and we will be able to, that's a challenge, we'll be able to wean the steroid on the CellCept alone.
Sorry, you were breaking up a little bit, Osama, but did I hear you correctly that you were treating the patient with steroid taper and MMF? Is that what you said?
That is correct. The MMF mainly was driven by pneumonitis. So we liked the idea. So we said this is something that it might help.
I see a couple of questions in the chat. One from Dr. Hall is probably for Charlie. Is megalin expressed in the tubular basement membrane?
No,
No. Okay. An easy
not
answer.
not in the basement membrane per se, just in the tubular cell.
Okay. And then Dr. Kerala, a question for Dr. Amro. Do you think drug exposure could have triggered this?
I'm not sure.
With the
I
acute
think our sense is that's the most likely, but it's hard. Tubular basement, anti-tubular basement membrane disease is not a commonly studied entity.
Could I just clarify, did the patient have an acute pneumonitis as well? And should we be doing indirect immunofluorescence on the pulmonary, on normal pulmonary tissue as well?
That's a good thought. I don't know if that was done.
Right. So, Ashley, can I speak up? I'm really sorry you raised that possibility. The lung is filled with artifacts because of all the elastin when you do these studies. So before we had anti-GBM assays, before you were even a nephrology fellow here, we used to diagnose anti-GBM with indirect assays in lung and kidney. And Mark Wenner and I were charged with that. We hated doing the lung. We stopped doing the lung. The kidney is clean, the lung is a mess.
Any suggestion in the immunosuppression regimen, giving like rapid improvement of creatinine? Do you think we are on the right track, or there is other options that we should explore?
Well, it sounds like the proof is in the pudding. You've had a great response to therapy. So I think you're clearly on the right track. I think it would be interesting to do serial titers and see what's happening to this anti-TBM antibody.
I'm just curious, Osama. I mean, I think it's not appropriate now, but did you consider in the beginning the possibility of plasmapheresis?
We just felt that there is no lung hemorrhage, and there was some improvement of the creatinine before with the steroid. So we felt that, you know, we have some time.
Sorry, Raymond suggests, could it be considered to perform Western blot analysis to further identify the TBM protein?
Well, actually, I was thinking along Raymond's lines as well. What about immunoprecipitating and mass spec? Because there's a very sparse literature on this. They've identified some specific proteins by molecular weight. So there seems to be, a few antigens, but they didn't go any further to identify what the protein might actually be. But with the tools we have now, I wonder, since this is such a high affinity serum, to use it to immunoprecipitate the antigen.
Ram, can you expand? I'm curious how you would do that. I think others are wondering how we could maybe identify, what is the antigen here.
So this is the same playbook, that David Salant and Larry Beck have used for membranous, right? I mean, we use the patient's serum to immunoprecipitate proteins from normal kidney tissue lysates. It'll be a little trickier because basement membrane and extracellular matrix lysates require a little bit more processing to solubilize basement membrane components and ECM components. But then you would try to immunoprecipitate, you would use the antibody from this patient's serum to pull down, specifically enrich for proteins that it recognizes in a normal tissue lysate. And that you can actually, if there's enough concentration, you can run it on an STS page gel and stain it, and you can see a protein band, which you can then cut out and run on a mass spec to identify the identity of that protein. And so it works best when you have a high affinity specific antibody, and it sounds like, you know, this was titering out even greater than 1:640. And so it could be an interesting experiment to try to identify it, because it hasn't been done before.
So along those lines, I'd say it also invites a very natural control of using lysed cortical tissue and lysates of medullary tissue. But Osama, every time there's a blood draw on this patient, can we ask that the serum be saved, spun down and saved, rather than discarded as the way clinical samples typically would be after a couple of days? There's a real value in conserving serum in this patient for the reasons you just heard.
Yeah, the logistics were very hard, but we will try in the Japan to see how can we get this taken care of with each visit.
Yep.
Yeah, because you might expect with treatment, if the titers are going down, if you do this, you know, like an immunoblot assay on the same amount of lysate, you might expect that the reactivity is going to go down over time as well. It would be a surrogate assay for the, you know, the indirect immunofluorescence staining.
Yeah. All right. So I think should we go to case 2?
I'm ready for
Thanks
case
very
2,
much.
but no one else is. That was really great. We'll see if I can follow up on that. All right. So I hope you can all see my screen. I hope everyone likes the flashy title here. So this is a patient where the biopsy was referred to us. The patient has been seen at UW, but they're waiting to be seen by UW Nephrology. So I've seen an EPIC, believe it or not. I've found some information in it that the patient has been scheduled for an appointment with one of our nephrologists, and that's been canceled but rescheduled. So you may be encountering this individual in the near future. Okay. So what is the clinical history? This is a 71-year-old woman with hypertension and hepatitis C that's been treated with Harvoni. She presented with fatigue, diarrhea, decreased oral intake, and had received her first COVID-19 vaccine approximately 10 days before presentation. She has intermittent shortness of breath, diarrhea, decreased urinary output, all since receiving this vaccine. And when she went to the emergency room, she was noted to have acute kidney injury and hyponatremia. She had a chest X-ray, which demonstrated bibasilar atelectasis versus an infiltrate, and clinically she did not appear to have any pneumonia. At that time, the illness was presumed to be secondary to the vaccine. She was given a liter of normal saline and then admitted to the hospital. And the initial assessment by nephrology deemed her to be stable, hemodynamically conversant, and then complains of feeling run down and tired ever since getting her first shot of that COVID-19 vaccine. Past medical history has some anxiety, arthritis, balance disorder, again, hep C that was treated, low back pain, reflux, and urge incontinence. Surgical history, she's had a bone marrow biopsy, she's had bilateral carpal tunnel release, she's had a previous transfusion, rotator cuff repair, and bilateral shoulder arthroplasty. Medications, here's the list. Nothing, really sticks out too much, sort of expected for given her past medical history. And her social history is not terribly interesting either. She smoked for 3 years and then quit 49 years ago. Family history is not very contributory. There's prostate cancer, some alcohol abuse, and polio in a sister, but no kidney disease history. And her physical exam is really noteworthy for her hypertension and no other significant findings. And here are her labs. So she was anemic, had low platelets. She was hyponatremic. Potassium was elevated. She was acidotic as well. She had a low CO2, low calcium, and she had acute kidney injury. So her serum creatinine was 6.47 at the time of admission. She also had an elevated glucose, not sure when the blood draw was, so that could just be postprandial or something like that. She did have some proteinuria, so the PCR was 1.6, and she had low complements, both C3 and C4, notably C4. The SPEP that she had done demonstrated two biclonal, biclonal components, IgM kappa as well as IgG kappa. So the assessment at this time is generalized fatigue, as mentioned, also thought to be suspected to be due to the COVID-19 vaccine, and stable and just continued supported care. Again, the acute kidney injury, really thought that is probably related to this vaccination, and just continue the IV fluid hydration and avoid any nephrotoxic meds. They're also going to rule out an obstructive component because she was having low urine output as well. Hyponatremia, again, thought it was due to the hypovolemia. Again, the acidemia as well, all pointing back to this vaccination here as the likely cause. And then the other notable findings are stable and not really contributing to her current hospitalization. Well, her hospital course didn't go as planned. She developed acute hypoxic respiratory failure with worsening hypoxia that was thought to be due to a volume overload, and she continued to have poor urinary output, which was treated with IV diuretics. So without any clear improvement in her kidney function, the decision was made to do a biopsy on day 5 of hospitalization. So is there any thoughts, any differential diagnoses that people want to throw out here for this individual? Or is it all just COVID-19 vaccine-related acute kidney injury? Is that the only thing we should be thinking of?
Did the patient have hematuria and proteinuria?
They had proteinuria. They may have had a little bit of hematuria. I can't recall offhand.
And I presume this is the mRNA-based vaccine, Pfizer or Moderna?
Yes. Okay. Any other additions, or do you want to go right to the biopsy?
Just a comment from David that, just a reminder, there have been case reports of minimal change disease post-COVID vaccine. There's one vote from a fellow for cryoglobulinemia.
Okay.
Does seem like it's an immune complex mediated disease triggered by nanoparticles from maybe from the mRNA vaccine.
All right. So we have a few ideas out there. Why don't we take a look at the biopsy and see what that shows us? So here's a low power view of the biopsy. Again, a decent sample of renal cortex. And at low power, there's a lot of good things to note. One is that there's a lot of tubular parenchyma. There's a fair number of glomeruli that still look like they're patent. There are a couple of globally sclerotic glomeruli. There's a little bit of tubular atrophy and areas with some interstitial inflammation. Looks relatively non-specific. So minimal chronic injury at this low power, and some glomeruli that we should take a little closer look at. And so here's then a little closer look. We can see some of the areas with tubular atrophy. You can see the silver positive staining in the tubular basement membranes that really accentuates the atrophic tubules. There's some of these mononuclear inflammatory cells adjacent to these areas of tubular atrophy and interstitial fibrosis. And we have a couple of globally sclerotic glomeruli. And then we have these glomeruli here, which are patent, but they do look abnormal, and they look hypercellular, they look fairly eosinophilic, they look like there's potentially something going on. And here's another look as well. We're seeing more of the same findings. Again, you know, what's going on in the glomeruli. And so we'll take a closer look here. And here we see this glomerulus that has capillary loops that are filled with many things. In many areas, we see increased cells. In other areas, we see this prominent globular material. So this eosinophilic globular material that's just occluding the capillary lumina. So many of the capillary lumina actually appear to be filled or stuffed with cells or globular eosinophilic material. And so this has a histologic finding that really raises our concern for cryoglobulinemia, which was mentioned. Here's another glomerulus here showing, again, prominent globular material contained within the capillary loops, as well as some increased cells. And then another. So most of these glomeruli are actually filled with globular material. Here we do have a few red cells that are making it through. So this could be one explanation for the low urine output, is that they're really, the glomeruli are actually occluded by a lot of this eosinophilic material. A PAS stain shows that most of this material stains positive for PAS, so that to us means that it is something that has some carbohydrates attached to it, and so that would also fit with cryoglobulins, since the immunoglobulins have carbohydrates attached to them. And then the Masson trichrome stain also shows that they're fusinnophilic, so they have the deep red stain that we really commonly see in immune complexes, again fitting with the tinctorial properties that we would expect for a cryoglobulonemic glomerulonephritis. And even some of the globally sclerotic glomeruli are involved too, so there's still some vessels that perfuse through these globally sclerotic glomeruli. Well, they even had to join in on the fun and get a few of these deposits, occluding their rare capillary loops that are still remnants within the scarred glomerulus. Immunofluorescence shows very trace staining for IgG and then strong staining for IgM. So it's an IgM dominant process. And then the kappa lambda staining shows strong staining for kappa and then trace staining for lambda. So we have an IgM kappa dominant process. The electron microscopy showed one finding that we really didn't expect, which was actually the presence of thin glomerular basement membranes. And so in some of the patent capillary loops, we noted thin basement membranes that were about 100 nanometers in average thickness, which was not expected. What we did expect to find, and we found plentiful examples of, were occlusion of capillary loops. So here's glomerular basement membrane, and here's a leukocyte occluding a capillary loop. And then here's another capillary loop where we can see this thin glomerular basement membrane. And this one is occluded by osmophilic material. And these then are the immune deposits that we were detecting. The podocyte foot processes are effaced almost everywhere within the glomeruli. Here's a higher magnification. We can see maybe some vague substructure here, but nothing that's striking. We can see the endothelial cell here, not a lot of fenestrations, and a little bit of electron dense material underlying the endothelium, and then this thin glomerular basement membrane. And here's some of the podocytes here on this side of the basement membrane. In other areas, we can see, again, some expansion of the subendothelial region, and then maybe a little bit more substructure within the immune deposits. Here's a higher picture, again, showing a cell process as well as some of the immune deposits in the subendothelial region, showing some vague substructure. And here's another capillary loop that's filled with a whole mixture of things. We see electron-dense deposits, we see some red cells, and then we also have some endothelium and some processes and immune deposits that are filling this capillary loop. If you look in some areas, you can maybe think, oh, maybe there's some vague microtubular-like structures, but it really wasn't absolutely convincing that we have, definitive microtubular substructure within the deposits that we found. So what else did we see by immunofluorescence? And this is something I want to point out here. This is an IgM stain, and you notice these cells over here, which here's a little higher magnification picture of this. And these are plasma cells here, and so we can see that, oh, we could find occasional plasma cells in the interstitium. And they're staining for IgM, and they're also staining for kappa, but in that same region, we're not really seeing any staining for lambda. So this is an indication that, well, maybe there's a monoclonal process going on, that we see some of these plasma cells that are staining just for IgM and kappa and not lambda. So is this, the question then comes, is this non-specific interstitial inflammation that we're seeing here, is this something a little bit more ominous? Should we be thinking about a monoclonal process and a potential B or lymphoplasmacytic process? Here's some higher magnification picture of these infiltrates, and we can see that there's mostly relatively monomorphic appearing small lymphocytes without any clear atypia, and nothing to get us too concerned. But it's also good to get a heme path consult in a case like this. And what's noted is that we have these small infiltrates, and they're mostly B cells. So they stain positive for PAX5, which is a nuclear antigen expressed by B cells. So the predominant population is B cells. And they also show aberrant expression of CD43. So this makes them a little bit atypical or unusual, since they're also expressing CD43. And then if we look for some evidence of clonality, we see that the plasma cells that are associated with these infiltrates are staining essentially for IgM, which is shown here, and kappa, but not lambda. So we do have evidence that there is potentially a clonotypic process present within this biopsy, in addition to the cryoglobulinemic glomerulonephritis. So the final diagnosis, we have a membranoproliferative glomerulonephritis with features of cryoglobulinemic glomerulonephritis. We also have monotypic IgM kappa. I think the main question here is this a type 1 or a type 2 cryoglobulin? We also have a low volume infiltrate of abnormal small lymphocytes and plasma cells. And what does this represent? Does this really meet criteria for a B cell lymphoproliferative disorder of some sort? And then there is some chronic injury in the background, and also, as I mentioned, we found some evidence of thin basement membrane disease, which is of uncertain really significance in this case, since I don't know if it has really much clinical significance at all for this patient. So some follow-up labs were done, and we have documented elevated IgM and elevated kappa light chain with a normal lambda light chain and elevated kappa lambda ratio. The patient also was found to have a positive rheumatoid factor. And then the cryoglobulins were presumptive positive, and the precipitate was actually run out on immunofixation and shown to be IgM kappa monoclonal protein. So this led to a heme consult, and the patient had a bone marrow biopsy. The bone marrow was really not terribly interesting. There were a few of these, though. There's a few small lymphoid aggregates, and when immunohistochemistry was done, they essentially were just small B-cell lymphoid aggregates. Flow cytometry was done as well, but in the end they were left with essentially a normal cellular marrow with these B-cell rich aggregates and no increase in plasma cells. There's a small kappa restricted B-cell and plasma cell population that were identified by flow cytometry, and they also happened to find a small lambda restricted B-cell population in the flow cytometry studies. So the hematopathologist thought that the findings would support involvement by a B lymphoproliferative process with plasmacytic differentiation, and the diagnostic considerations would include an IgM monoclonal gammopathy of undetermined significance, or IgM MGUS, a lymphoplasmacytic lymphoma, or a marginal zone lymphoma. So clinical follow-up. The clinical diagnosis at this time is IgM kappa MGUS and cryoglobulinemia with renal involvement. And so, you know, some of the questions that I have is, well, should we call this MGUS, or should we call this monoclonal gammopathy of renal significance? And, you know, is this type 1 or type 2 cryoglobulinemia? You know, which one is it? I don't know if anyone has any thoughts or considerations that they would like to share. Well, we can catch up with those in the chat, but anyways, think about that and what you'd like to add. The patient was started on high-dose prednisone and showed improvement of kidney function, no need for dialysis. Currently, they're on prednisone, 50 milligrams once a day. There has been some consideration for adding rituximab or bortezomib. After hospitalization, the patient was discharged to a skilled nursing facility and planned for future transfer to assisted living facility. And the most recent creatinine was 1.8 milligrams per deciliter. So, you know, what about this question of cryoglobulinemia and type 1 versus type 2? And in this instance, it's a little bit complicated, right? Because we have this, what looks like a B-cell lymphoproliferative disorder present in very low volume in the kidney and in the bone marrow. But we also have, you know, there's a little bit of IgG staining and a little bit of lambda in addition to the strong IgM and kappa staining in the glomeruli, and they do have a positive rheumatoid factor. You know, so what are the things that help us differentiate these things? And this is from a perspective in blood that I pulled this table, and I think it's still confusing after looking at what we know. And so here's some of the clinical findings. This patient does have glomerulonephritis, but you can see that in both type 1 as well as the mixed cryoglobulinemia, type 2 and 3. Peripheral neuropathy, the patient does have a neuropathy. Arthralgia, they do have arthralgia. They're really seen in both. I think the cryoglobulin composition, we don't really know for certain what's going on in that instance. There is clearly a monoclonal component present, but I don't think we know the full characterization of that. And we don't really know if the rheumatoid factor that the patient has is the same IgM kappa that we've identified as the monoclonal protein. The cryocrit was actually pretty hard to find in this patient. In fact, at 10 days, they couldn't find any cryocrit, and they just had a precipitate from early on that they tested. So the cryocrit is low. It's usually higher in type 1. So this would maybe make you think maybe this is really a mixed cryoglobulinemia. And then complement assays, well, they may be decreased in type 1, and they're more commonly decreased in the mixed. And clearly this patient did have a low complement assays. And rheumatoid factor, this is again adds to the confusion, is that, well, it's increased usually in mixed cryoglobulinemia, but apparently it occasionally is increased too in type 1. What about underlying disease? Well, you know, you can have, clearly you want to have a monoclonal gammopathy, which we have in this instance. But guess what? If you have mixed cryoglobulinemia, you can also have hematologic malignancies, including Waldenstrom's macroglobulinemia, as well as some of the other things that have been concerned, been considered in this patient. Then the other question is, well, what about this recent COVID-19 vaccine? What does that mean? Is this just a coincidence? Did the vaccine aggravate underlying disease? And I looked back in the literature, and there's really not a lot of support for this. There are some rare reports of type 2 cryoglobulinemia post-vaccination, and that's really digging deep for hepatitis V vaccination, influenza, and pneumococcal vaccines, but these are just really sort of anecdotal reports. So it's not like there's a heavy, large body of evidence to help support this, and I think it's really largely speculation at this point. There is some other people that have considered this. So, there is a report questioning whether or not COVID-19 vaccination is unmasking glomerulonephritis. And as someone mentioned earlier in the chat, well, people have reported membranous minimal change disease after COVID-19 vaccination. So is that an association? Is it just by chance? Is there really something mechanistic behind it or not? I don't know. And so here is again someone that reported 2 healthy individuals that had hematuria shortly after vaccination. One of them had IgA nephropathy and the other had crescentic glomerulonephritis. So is this like, oh, the vaccine triggered this disease, or is this just, stuff happens? And I think, that's really where we are currently with this patient as well. So what about using COVID-19 vaccine in patients with immune-mediated kidney disease? Should there be any concern? And I think right now there's very, very limited data because patients with autoimmune diseases were excluded from the early vaccination studies. And so we're in a data poor environment, and this is largely expert opinion recommendations, so data poor recommendations. Based upon experience with influenza vaccination, there's not really a large risk of a relapse or recurrence of disease in patients with SLE or glomerulonephritis. So, it's thought, well, we haven't seen it with influenza, so it's probably not a huge risk. And I think probably the main rationale is that the benefit of vaccination outweighs, is that the benefit of vaccination is definite, right? Vaccine really works, and COVID-19 can be bad. So that I think is one of the major reasons to recommend it. And then the other aspect is that the perceived risk is low. So the risk that's at least perceived by experts is low. So vaccine works well, perceived risk is low. So I think the recommendation currently is to go get your vaccine. And if you do get something, that stuff happens, and we can't really tell for sure if the vaccine did it or if it was just, serendipity. And so I'll leave people with those thoughts, and curious to get people's opinions about this case and whether or not they have a clear opinion if this is a MGERS or a type 1 or type 2 cryoglobulinemia, or is this something that was triggered by the COVID-19 vaccine and that we should be concerned about?
It seems like with the bone marrow biopsy results, I mean, there should be at least probably some effort to look systemically for lymphoma. I mean, were there plans for scans or anything like that, you know?
I'm not aware of any additional workup that's planned beyond the bone marrow biopsy and all the serological testing that's been done for this patient.
I would think that since the B lymphocyte process is being considered either MGUS or benign by the hematologist, that they are not ready to treat it per se. And so we should probably consider this as an MGRS because we have a very distinct and severe involvement of the kidneys. And I'll probably go more with type 1 on the cryo here. And I don't think prednisone alone is going to cut it. This person should be, aggressively managed, probably rituximab, definitely.
Yeah, I might look at this a little differently. This to me sort of seems to fit along the lines of kind of a chronic hepatitis C type picture. I know the hepatitis C has been eradicated, but we commonly see cryoglobulins persist after eradication of the hepatitis C. And they did have a long-term IgM kappa, which would be consistent with cryos being present even before they had the COVID vaccine. And we often see a sort of a spectrum of sort of progression through MGUS to eventually lymphoma in these hepatitis C patients. So I think she probably had underlying cryoglobulinemia before, and just the vaccine was maybe a non-specific immune stimulant, which led to a flare in her cryoglobulinemia. So I would favor this as a type 2 and treat her as a type 2 cryoglobulinemia.
So the oncology people are seeing some recurrence of graft versus host disease, which was previously pretty quiescent and stable in post-stem cell transplant people. I have encountered one that I've taken care of with them. And also one of my patients, I'm pretty convinced, had a full acceleration of his amyloidosis following, who was very stable, and then ended up having very rapid pace of his amyloidosis in the heart, and actually passed away after that. So there is this concern that COVID vaccination, as you probably said, Ashley, it's like a non-specific immune stimulation is probably happening and driving some of these processes.
Yeah, I've reviewed a couple of cases, and I've seen or heard of a couple of cases of different GNs that have worsened after COVID vaccine. I think the problem is, we're all looking for the association, and we've all had patients in the past who've had a flu vaccine and suddenly had a flare in their lupus or minimal change disease. You just never know whether it's cause or effect or non-specific, or, we just don't have big studies to know if this is a common thing.
So this patient had their first dose and this happened. Should they get a second dose? And if so, how would you do it? How would you manage them?
No, they shouldn't.
They should get rituximab instead.
But if we're going to give rituximab, then I think they should get the vaccine, because rituximab would blunt the antibody response.
So, I mean, I think, what people have been discussing, and it's something that I've been thinking about too, is whether or not, the IgM kappa, B cell process that we're seeing is really just this monoclonal rheumatoid factor producing cell population that may have been around for quite a while. And, so was this, is this something that, really meets a true lymphoproliferative disorder criteria, or is it something that, does happen in the setting of hepatitis C virus infection and then, has this, properties that are concerning for a lymphoproliferative disorder, but really never turns into, lymphoma per se, or something that really needs to be addressed specifically for the cell proliferation process. Okay, well, I don't know if there's anything else to add other than the fact that I think the patient is trying to see UW nephrology, so maybe we'll get some follow-up and decide how the patient should be treated and whether or not she gets a second dose of the vaccine.
Thanks so much, Kelly, and thanks to both Charlie and Kelly for these presentations today, and to all of the renal pathologists for their teaching over the course of this year. We're forever grateful for that. And with that, we'll close and hope everyone has a great weekend. We'll see you next Friday.